welcome everyone to the official launch of the SEURO Horizon 2020 project. My name is Wolfgang Schmitt. I'm the Dean of Research here at Trinity College, and I will be the chair of this event. So to begin, I'm delighted to welcome first of all the Provost for joining us in marking the occasion, so thank you very much. And I would like to thank everyone for taking time out to attend the meeting. In particular, those who traveled across Europe to be here with us today at this event, to be here with us in Dublin. The acronym SEURO, or SEURO, stands for Scaling European Citizen-Driven, Transferable and Transformative Digital Health. The objective of the project is to evaluate key factors necessary to prepare any European region to implement successfully and scale innovative digital health technologies for multiple disease management. The project, which received 3.9 million euros from the European Commission under the Horizon 2020 project, is, in my opinion, highly innovative. It pushes the boundaries of the state-of-the-art of research, and it is very important for us at Trinity College. It represents an important milestone for the university as we are trying to grow our research activities in this area, in the area of digital health across the university. Many activities are obviously driven by John Dinsmore or colleagues from the School of Nursing and Midwifery, but any other activities across college are, for instance, also driven by the School of Medicine and the School of Computer Science and Statistics, also by our SFI Research Center, the ADAPT Center, focusing on personal digitalized digital health solutions through the application of machine learning and artificial intelligence and data management. In 2019, our provost, in her former role as Dean of Research, published a research charter, and she combined the research charter with a research excellence strategy. When you open this document, the first point in this research excellence strategy states that in deciding our path, our research path, we need to make the best use of our research expertise and research support that we have. And we also, importantly, need to look outwards at external opportunities and societal needs. I believe this project, this European project, really underpins the research excellence strategy. Reflecting on this project, we see the first building block of research excellence come to life. The project, in my opinion, harnesses the expertise from across Europe. It harnesses expertise across different disciplines, different sectors. It harnesses expertise from academia, industry, policy sectors, services, and obviously it tackles major societal challenges. Namely, the advancement of digital technologies to empower individuals to manage their health and well-being from home, and to successfully age in place. Tied to this is obviously also the decentralization of care to individual homes and increasing the future sustainability of our healthcare system and our social care services. Secondly, this project, as I mentioned, clearly pushes the boundaries of the state-of-the-art in research. However, when you also read the document, the project also recognizes that health research needs time. Health research, or in particular the research vision, needs alignment, for instance, with societal changes. In this case, the adoption of digital technologies, for instance, smartphones, into our daily life. Innovation requires alignment also with policies here, with European and national policies. And in some cases, the research vision also needs to align with global events, for instance here the COVID-19 pandemic, which also highlighted the capabilities of digital health solutions and technologies. So the SEURO team successfully, I believe, recognized these challenges. They recognized and navigated these challenges and opportunities. And I think the team first came together even already in 2016 under the Horizon 2020 project PROACT. And after this project, the team, I think, raised more than 10 million euros in national and EU funding, which is really remarkable. This achievement is a clear testament to the quality of the team, and it's a testament to the vision and dedication to research excellence. And with this, I would like to start the event today, and I invite the Provost to stage.
Thanks, Wolfgang. I think you did a very good job of summarising the project. I'm absolutely delighted to be here, and thank you very much for inviting me. It's a great honour to be here at the launch of the project. I was thinking about it a lot, and the reality is, you know, in any country, in Ireland especially, health is a big black hole. You can never put enough money in, you can never support all of the services that you need to. And we find the same in Trinity. We have some fantastic services for our students. Well, we like to think so. But I think the way the world is today, we can never support all of those that we need to support. And even if you look at the situation in Ukraine and the fact that we want to keep our borders open to people to move here, I think the challenges around health grow and grow and grow. So for me, this is a really amazing project that allows people to manage multi-morbid conditions, to manage them from home, as Wolfgang says, to age in place, which I think we can't underestimate the dignity associated with that, to be able to be in control of their lives, to have agency. So I think it's a fantastic project. I think the different elements of the project that are about understanding how you manage your conditions, but also understanding the underpinning issues around the behavioural changes that you need to drive and instill in people is hugely important. And for me, one of the enormous things about it is actually the fact you're genuinely interested in scalability. And I suppose I'm very inspired by the project on a number of different levels. I think the PROACT project led by John was fantastic. I've heard a lot about that in the past. But very often with EU projects, when we get to the end of one, we kind of discard something. And what's really, really impressive for me here is that you're actually building on the PROACT project. You took it, you did a proof of concept, you showed that it was possible to do things with it. And now we're gearing up again in really making it usable and useful through working with the fantastic partners around Europe, through working with IBM and others. And I think that's what makes it really, really impressive. And that 10 million euros that Wolfgang mentioned is all about building on that PROACT platform and using that to really, really make something happen. And I often find, we've had a lot of debate when it comes to research about when you finish a project and how it's only sometimes after the project is finished that you can make the impact. So here what you have is something that takes up where another project left off and really affords us the opportunity, or you the opportunity, to make incredible impact. I was totally impressed by the figure, and I hope it's true, that you could potentially reduce hospital admissions by 30%. I think that's a fantastic aim. And if you really do crack this nut, which is a very, very hard nut to crack, I have to say, I think it can make a significant difference. I mean, I think in the countries we are all from, and I think with the European spirit, we do want to be able to support our populations and provide the care that they need and deserve. So I applaud you all for this. We had a debate at the beginning of how you pronounce SEURO, and Wolfgang suggested it was SEURO, and John told me it was SEURO. But to me, actually, the way I look at it, you could think of it as SEURO for saving euros, because I actually think, because your long name is not one that trips off the tongue, John. And I think it genuinely has the potential to do that, but saving people in terms of, I said, kind of dignity and respect, in terms of agency, in terms of people being able to be in control of their own lives. So I think it is a fantastic project. I am delighted to be here, and I just want to say a small few thank yous. So obviously, thank you to the European Commission. It's 3.99 million funding project from the European Horizon 2020 research. I'd also like to thank the Trinity Centre for Healthcare Practice and Innovation and the School of Nursing and Midwifery. I agree with Wolfgang completely. We here in Trinity have seen so much innovation in this space. And I think there's plenty scope actually for much, much more, and this is just the start of many things to come. I'd really like to thank our partners from Italy, Belgium, Sweden and Austria. One of the amazing things about European projects is that ability to reach out and understand different cultures and garner different expertise. And I suppose it's very exciting that people can actually travel again to experience the cultures of different places. So you're most welcome here, and our partners in IBM and our partners from elsewhere in Ireland. You're absolutely most welcome here to Trinity. And of course, then I also want to thank John Dinsmore as the coordinator. I've known John a long time, and I'm always very inspired and impressed by all that he does in pushing this forward. And Wolfgang spoke about the different parts of Trinity that are interested in digital health, but you need somebody with passion to kind of look out and join the dots and bring those things together there. And for me, certainly John is that person. So I'm very proud of all that you do here and that we're hosting the project. So the best of luck and huge congratulations. I know the project has been in place a while, but huge congratulations. And I really, really do look forward to the difference that you are all going to make to people's lives. So thank you very much.
So thank you very much, Provost, for a very inspiring welcome address. So now I asked John to come to the stage to tell us a little bit about the project and explain a little bit what the project is about.
Okay, thanks. Thanks, everyone. Thanks for the kind words, Provost. That was fantastic. When I first came to Trinity 10 years ago, around about that, I contacted a number of PIs to get advice and guidance, and the Provost was one of them, who met me in the Science Gallery, sketched out a few ideas, got some pointers, and I think it might have paid off a little bit where we are today. So thank you very much, and thank you for taking the time out. It's Trinity Week, a very busy week here in the college, so thanks for taking the time out to launch the event. Also thanks to our Dean of Research, Wolfgang, for chairing the event today. I really appreciate that as well. To everyone who took time to attend out of your busy schedules, including our European partners, it's great to have you back in Trinity after so long. And that's where I want to pick up, because as the Provost said, this project has a bit of history, and I have to go back a little bit to explain how we got here today. So I'll do it very quick. I'll not drag on too much, I hope. So this is back in 2016, and we launched the PROACT project. And you can see actually in this corner, the team on the night of the launch there, Professor John Boland was the Dean of Research at the time. We all are pretty fresh-faced. I have less grey hairs than I have now. And naivety is a great thing when you're starting huge research projects, but you do learn a lot. But it was a fantastic project to be a part of. And that project at the time got 4.87 million. It was a 44-month project, and we had a couple of core objectives. The first was to develop and trial at proof of concept level a digital platform to support older adults with multimorbidity. And we built the platform to encompass a number of different conditions that we saw as most prevalent, so diabetes, chronic obstructive pulmonary disease, chronic heart failure, and diabetes. The second would be that we would advance this platform in terms of a shift towards community-driven care, so looking at how we could look at a proactive model of community-driven integrated care, allow people, empower people to self-manage at home and let them link in with healthcare professionals to be part of the dialogue around their care. The third was to try and understand some factors, really the barriers and facilitators for organisations and services in terms of scaling these particular technologies and practice across the EU. So this was the PROACT platform, which we'll trial in SEURO, and I'm going to quickly take you through it from left to right. So at the heart of the platform is an application for older adults to self-manage. So they can manage their vital signs, for example, blood glucose, blood pressure, weight, and also well-being, so sleep and physical activity. And we tailor the platform to particular condition types. So if you have COPD and diabetes, you might get a digital blood pressure cuff, you might get weight scales, an activity tracker, SpO2 meter, and digital glucometer. You can see here, we can gather a lot through sensors, but anything that we can't gather, we do through self-report. So this person has COPD, we would ask them to self-report around things like phlegm amount, colour, chest tightness. Now they can track their activity daily, weekly, monthly. They can see trends. We have algorithms in there that then allow them to look at training and education to better self-manage, and we do help them with that, help them set goals around their health and well-being. We also have applications for the care network. So healthcare professionals, informal caregivers, formal caregivers, including also pharmacists. So that person at home can be connected to their care network, interact with them to better inform how they should self-manage at home. At the heart of, at the middle here is the data aggregator CABI SIMS, and this is mission control. This is where we have oversight into everyone in the trials. We actually developed this. This is part of research, really. We didn't have a system to have oversight of all the persons in the trial, so we built one, and this was built by DkIT, and really it allows us to see how people are using the technology. We can then aggregate data at an individual or population level to look at trends in their health and direct them in terms of their healthcare. We can see if they're doing well or not, and if we need to escalate a particular person because maybe they're not doing so well, we can do so. But we can also optimize and personalize the apps through this. So we can tailor content. We can change the features for each individual, and that's part of the behavioural change strategy as well, to maximise engagement with the technology. Following that, we then built a version for triage nurses so that they can look at all of the patients in the trial, and through the parameters we have, the clinical guidelines that we use, if people are falling outside the norms in terms of their particular symptoms, we can then escalate and intervene as well. And then finally, with IBM, we built Interact. And Interact is a series of advanced analytics to really look at how we could make much more sophisticated risk prediction in terms of health and well-being. At a global level, what we're trying to do is take population data sets, build models of people in a particular region. So if you're 73, you have diabetes, COPD, and a history of falls, what are the other risks that you have in terms of your health and well-being from that caseload in the population, that historic caseload? Then take that data from the population and map it onto the ProAct user so we can identify maybe trends for you relevant to historic cases. So it's a very advanced way of looking at healthcare. Just some numbers around ProAct at the time, and this really emphasises the work that went into it. We had 409 individuals help with the development and creation of it. Our first phase in that first year, we had 184 individuals. So that's persons with multimorbidity, healthcare professionals, informal formal care, helped us understand how you design this. What do we need? What features do we need to engage individuals? We then did a 12-month longitudinal action research study to look at issues around acceptability, how people are interacting with the platform, and particularly engagement. And we did 2 trials, one in Belgium, one in Ireland, 120 persons with multimorbidity and 73 in their care network. So that was where the individual with multimorbidity invited, for example, GPs and family members and formal caregivers to get involved. With the Interact platform, we used the tilted data set here at Trinity, and we trained the initial models with 8,504 individuals from that platform. And then finally, to understand factors around transferability, we did a 3-stage Delphi study with 17 experts across 15 EU member states to look at those barriers and facilitators to implementing digital health solutions. Now, as you can imagine, we have a lot of outputs from this. We have over 30 peer-reviewed scientific outputs, and we have more in press and in development, and we had 84 reports to the Commission. So lots of data generated, lots of evidence. But I want to just touch on 3 key outcomes that then led to SEURO that helps explain where we are today. The first was engagement. So what we noticed in the 12-month trial was people were engaged, and once they were set up on the platform, they engaged. You can actually see the recruitment curves in Ireland and Belgium here, and you can see where people stayed on the platform. They were taking about 2 to 3 readings per day in line with what was requested of them. So the key question from a research perspective is, if they're engaging longitudinally, which is one of the big issues around digital health, getting over the novelty effect, why are they doing so? What elements of the platform are enabling this? We need to understand more. The second was the transferability study from that study we did, the transferability model. And we had 17 factors, and we broke them down into essential and relevant for organisations and services to understand in order to prepare them to take in a digital intervention. And then we broke it into 4 domains. The solution itself, if you're bringing in, can you trial it? Is it adaptable? Looking at the organisation in terms of your leadership and training and culture, the processes then within your organisation to bring it in terms of your planning and your engagement with key people involved in that process of implementation, and then finally individual specific, and that's really around the confidence of people when you bring it in to use the technology. And then finally, this came from more learnings around the research and the trials. We developed a ProAct behavioural change framework, and it's a 7-step systematic process. And it's targeted at, developers, designers, and implementation teams to try and understand, are you bringing in key requirements to ensure that the intervention you take is likely to change behaviour in a positive way, that people will engage with it. So that's initially being empathetic in that first level to look at user needs and requirements. The second level is around bringing in behavioural change theory to personalise it, and we give advice on that. And then the final is to look at your trial design to understand, are you trialing your intervention at the correct level? How mature is your intervention? Is it proof of concept? Is it more established? Are you bringing in the correct trial design? And are you looking at the key metrics in order for you to have an evidence base to bring it into the particular region in Europe that you want to take it in? So that's aligning with procurement and metrics like healthcare utilisation metrics or quality of life that a lot of health services would demand to see evidence of. Just a quick shout out, because when we finished in 2019 going into 2020, we have also some national projects that helped inform this. And we have the SMILE project that was led by CareDoc and linked in with Trinity and DkIT, using the ProAct platform to look at triage nurses and how they use the platform, and a project in Bogenberg where we extended the use and understanding of it for a younger cohort under 65. So from that, and as Linda said, we wanted then to take all the evidence from those trials and from those 3 key areas that I spoke about to bring them into SEURO. So we got the band back together, and we used kind of a musical term there, but we just changed the lineup slightly. We brought in our Swedish partners in UMEÅ and Region of Västerbotten. We had 3.99 million, and we have a 3-year project, and as the Provost has said, we're already in the first year, but we wanted to bring everyone together to celebrate this. So really, the aim of SEURO is to evaluate key factors to prepare organisations, localities, regions across the EU to scale, sustain and transfer people-centric, digital integrated health and social care solutions for multiple disease management, or SEURO. I definitely need to learn how to refine these statements a little bit here. But to achieve this, we are going to build 3 tools, 3 digital assessment tools for organisations to help them prepare their organisations to bring the tools in. And the tool that we're going to use for them to bring in to test these tools is ProAct. The secondary objective of that is to look at more the effectiveness of ProAct as well. So we're going to test the tools and look at the effectiveness of ProAct in one project. So the 3 tools, we're going to take the ProTransfer model, and we've built already. It's a digital self-assessment tool for organisations to understand their level of readiness to transfer, and we're working with health services on that. The ProBCFC, so we took our framework and we've developed a checklist for designers and developers and implementation teams to know how to bring in the correct theory to practice. And then finally, ProInsight. This is where we're taking Interact, the model, and we're advancing it a little bit. So not only are we taking the population data in and building models, we're going to expand in the data sets now to Belgium and Sweden. So we have 3 regions. We're also going to look at the outcomes from these tools as well to see, basically take the population data, take the data from the interventions that's trialled and from the tools to see, can we have a predictive algorithm that would inform healthcare services, 1, of the potential cost effectiveness of the solution when they bring it into practice, and 2, to understand the impact for the patients that might be using them. So that's the grand vision. Quite ambitious, but actually it's coming together. And finally, to do this, we've 2 key trials that we're going to run starting from October. The first trial is off the ProAct platform. It's an effectiveness implementation hybrid trial design. So that's a pragmatic randomized control trial with a process evaluation built into it. So the pragmatic RCT is 3 arms. It's the full ProAct intervention with the triage service versus a basic application model in ProAct but doesn't have the analytics or the triage services versus standard care. And we're trying to understand as a primary outcome there cost effectiveness. So we're looking at two key outcomes, quality of life and healthcare utilisation. So what we're trying to establish is, if we took this solution and we wanted to bring it into practice, is there an argument around it being cost effective? The secondary outcomes are then to look at the actual platform itself in terms of acceptability, user engagement, and to try and understand a little bit more how people are using it to manage their health, how they're using it to stabilise symptoms. One of the things we saw with the original PROACT project is over time, people were learning how to stabilise symptoms, the number of exacerbations decreased, and the number of links into the triage service as well decreased. And then finally, we're going to do a smaller trial, just to touch back on the effectiveness implementation hybrid trial. We'll have 720 older adults, 240 per arm, and that will be across Sweden, Belgium and Ireland. The inclusion criteria is over 65. We've expanded those that we can include on the remit of the platform, so it's any cardiovascular disease excluding vascular dementia and stroke, any respiratory condition and diabetes. Moving on then just to the last piece here, the inductive simultaneous exploratory trial. Fancy name, but really what we're doing is we're taking the tools that we've created, ProTransfer particularly, and trying to understand whether it can set a potential procurement process for services. So if you're taking a digital health intervention into practice, could you use the tools to set the guidelines for a procurement process so that you understand that the service that brings it in is at a readiness level to make sure or maximise the potential of the intervention. And with all that, I'll conclude. We hope to make those tools freely available at the end of the project for services. It's important that we get it out there and hopefully bring PROACT then to societal use. And there's our Twitter, our website, and you can email the team as well if you want access to the papers or any of the other content. Okay, thank you.
So thank you very much, John, for a very fascinating presentation of the project. And it is really interesting to see the origin of the project arising from PROACT, and it's absolutely fascinating and with a huge, huge societal impact. So what we will do now, we will ask the partners to come to the front. I think we prepared chairs here, and we will introduce each of the partners that contribute to the project. The partners will have an opportunity to provide to give insight into the role of within the project, within their roles, what it means for their institution to be part of this project, and how they will advance digital health research within the project. So I welcome the partners within this project. So probably each partner can probably give a little bit an overview over their contribution. So the first one is Dr. Julie Doyle, Director, NetwellCASALA, Dundalk Institute of Technology. So please give a brief introduction.
Thank you, Wolfgang. Good morning, everybody. So as Wolfgang mentioned, I'm Julie Doyle. I am one of the PIs on the project based in NetwellCASALA in Dundalk Institute of Technology. And John gave a great overview of the project. So we are leading on the design and development of the PROACT platform, and we're also leading on the trialling of the platform. So we lead the EIH trials. So basically, it's very much accepted, I guess, at this point that digital health technologies have the power to transform healthcare in Ireland. So we have an ageing population, increasing prevalence of chronic disease, a shortage of healthcare workers projected in the future, and rising healthcare costs. So we really need, I suppose, innovative digital solutions to help people to manage their health and well-being at home and in the community. And the COVID-19 pandemic has really only served to amplify this need, but it's also highlighted to us that we can adapt and adopt new digital innovations when needed. So hopefully we'll see this continue into the future. So Ireland is really a global hotspot for digital health innovation, both from the research perspective and also in terms of the level of commercial activity we have here in Ireland. So one of the key requirements of digital health is obviously to empower people to use it, to be able to use it at home, as I mentioned, to manage health and well-being. So an empowered person will have more awareness of their health and well-being, they'll have better outcomes, they'll have a better understanding of how to navigate healthcare systems. And digital health researchers and companies alike really are, I suppose, recognising the importance of taking a patient-centred approach to the design and development of digital health technologies so that we can support and achieve this kind of empowerment. Without the voice and the lived experience of those who are eventually going to use these technologies, digital health technologies have really little chance of success. So SEURO and its predecessor PROACT really put older people and those who care for them at the centre of what we do. We implemented a very much an iterative user-centred design process in PROACT. We engaged with older adults and those who care for them right from the very start of the project through every stage of it. And this engagement occurred. We looked at generating requirements, as John mentioned, at the very start. People helped us co-design the platform, and then they evaluated it in the trial. So as a result of this, during the trial, as John mentioned, we saw really very high levels of engagement from older adults using this technology at home, as well as important outcomes such as improved self-management, better clinical outcomes, and greater knowledge and confidence to self-manage. So the high levels of engagement observed during PROACT demonstrate the willingness of older adults to actually engage in digital self-management. So it's an important finding, and it highlights the importance of recognising older adults as users and consumers of this type of technology. And over the years, I suppose, at NetwellCASALA and Dundalk Institute of Technology, we've been working with older adults in designing and developing various digital health technologies, and I think we've often met with quite a bit of scepticism about the ability of older people to use these technologies and the willingness to adopt them. And I think it's great seeing projects like PROACT and SEURO with evidence coming out with this engagement that actually show that older people really do want to engage in this type of technology and find it useful. It also demonstrates that adopting a person-centred approach to designing these types of technologies actually works. So following PROACT, as John mentioned, some of our partners, CareDoc, ourselves, and Trinity, we got funding through the Sláintecare Integration Fund to implement the PROACT platform through the SMILE service. And I think that was great because it's the first step towards moving, I suppose, from a research project into sort of a clinical implementation. And the SMILE service has been running since February 2020, and there's great outcomes coming from that as well, and the CareDoc team have been fantastic in providing triage and that. But it demonstrates the need, the continuation of the funding sort of demonstrates a need for this type of service. And the goals of Sláintecare, I guess, they align perfectly with those of SEURO and PROACT, which are to promote engagement and empowerment of citizens in the care of their own health, to scale and share examples of best practice and processes for chronic disease management and care of older people, and also to encourage innovations in the shift of care to the community. So Sláintecare, alongside other innovations in the Health Service Executive, including the Digital Transformation Initiative, whose aim is to drive digital competence, capability, capacity and change within the health system, demonstrate the willingness of Irish healthcare providers to really embrace person-centred digital health solutions. Thank you.
Thank you very much, Julie, for fascinating insights into the project. The next speaker will be Paul McAnguza.
Yeah, I get that reaction.
Senior Manager Healthcare Research, IBM Dublin.
Thank you, Wolfgang. Thank you very much. My name is McAnguza. It's difficult but it's just Paul McGuinness in English, and I get confused with the manager of U2. So, Linda used, if you'll permit me to call you Linda, Linda used a very interesting word at the beginning, passion. Right, you talked about the passion of the team, and I think I was here about 6 years ago. It was over in the science gallery, I think, when we were upstairs, when there was a science gallery, and we had the kick-off for PROACT. And certainly that passion hasn't decreased. And so, I think of this as a privilege to be able to continue on this journey, because most of what you want to see when you work on a team like this, and John, it's probably less a band now, it's more like a super group. When you get all these aging rock stars together to kind of pull off some top hit in the charts. But that passion is still there, because when we look at projects in IBM, and by the way, we get a lot of people asking us to participate in Horizon and EU projects in general. We really do look at them through a couple of different lenses. One is, is this a project worth doing? because we could put our money in lots of different places. We don't get full cost recovery from these projects. So every one of these projects is an investment for us. And so IBM is paying for my time, for Alessandra's time, for Francesca's time, and investing in these projects. So we really do get asked, is this worth working on? And I think you have to say, changing the trajectory of healthcare for people, and we'll all be one of those people quite soon, some sooner than others, is a really, really, really important problem. And it's a problem that we are heavily invested in across IBM research. So we're one small part of a worldwide team here working on related problems all around the world. We have colleagues in Tokyo doing the same. We have colleagues in the US doing the same, and so on. And as I said, it is a privilege to be part of such a passionate team working on such an enormously important problem. The real goal for us in these areas is to work, as I said, on high-impact problems, but to bring our technologies to play, because we're actually not much of a technology company, really. We don't make most things. I don't think there's anything in your office that has IBM written on it, unless you have an old typewriter or something that we used to make 50 years ago. We don't really make things in the sense that most people would think of technology nowadays. And so most of what we do is finding these really interesting problems and applying technology to try and solve them. Recognizing that, particularly in areas like healthcare, where we've got enormous societal problems, no one group can do it on its own. So it needs to be a supergroup to come together to try and progress these types of problems. The other things we look at are, can we do it? Because we do look through who the consortium members are. We really like working with this team, because as I said, about 6 years ago, we all started trying to figure out how to do these things. We've survived through COVID together. The deliverables have kept coming. The recognition for the project is incredibly high. So in that sense, this was a really easy investment decision for us to make. Yes, we want to be part of this team. And so, when I come back to why digital health, because the time is now. It really is now. If you look through the European funding portal, everything from RIAs to EICs and so on, digital health is everywhere in terms of interest and investment. If I look in the US, the big seminal change was during COVID, when the government changed the waiver scheme to actually move some of the standard treatments to remote via digital health. And all of a sudden, it's blooming in the US now because they changed the waiver system. The funding is there. And that brings me to one of the really interesting and I think novel aspects of this project. I'm tired of seeing technology that looks great in the lab just not get out of the lab. And Linda, you mentioned sort of European projects and what trace do they leave behind at the end. Here's something where you've got a really structured approach. You're looking at the business, you're looking at how the technology will progress. How can we get this technology out into the field and into the hands of the people who need it? And this project is really unique in trying to do that, because I don't know about you, but I personally am sick of working on things for 3 years and then just not seeing them go anywhere. Right? Maybe you get an extension, maybe you get some more funding. This one is going to be different. So I'll challenge you at the end. Anyone from Ireland who did their leaving cert at a certain time knows about a novel called PEG. and there's a thought in there that these people living on an island in the far west of Ireland, right, completely remote from any type of digital system, right, need to be completely self-dependent, independent, had this notion that your life is spent in periods of 20 years. It's all good at the beginning, right, but at the end, the last thing they say is, your last 20 years are fihiblion gan wai. Now, for those that don't understand, that means 20 years of not being of any use. Right? So that's the idea that for your final 60 to 80, right, whatever your lifespan is, you become a burden. And this is what this project, I think, promises to change. So I challenge you, right? Change that from fihiblion gan wai to be fihiblion lan the wai, right? So that you are full of goodness and full of use and full of energy for that last 20 years of your life. And do it quickly, please, because I'm approaching it too. All right? So I know my time is up. We are fantastically thrilled to be part of the project, and I want to thank everybody, faces old and new, Trinity College for the facilities that you've provided today to kick the project off, and for your obvious support for the project. So I'm looking forward to having my final 20 years of whatever it is that you deliver in this project. Go and do it. Thank you.
Thank you very much, Paul, for explaining what your motivation is and why you actually choose to be in this project. And thank you very much. The next speaker is Evert-Jan-Hoogerwerf, Head of Sector Projects for Innovation, AIAS, Bologna, Italy.
Thank you. Good morning, everybody. Thank you for the introduction. It's great to be back in Dublin. And thank you for Trinity College to have us here for the launch. We are very proud to be part of the SEURO project again. We were already part of PROACT. And actually, I have to thank Trinity as well, and especially John, because the center that I currently direct, the We Care More Center for Research and Innovation of AIAS Bologna, is a direct output of the PROACT project. So that's actually amazing. We managed after that project to keep together the team of researchers and technicians and occupational therapists, psychologists, a very multidisciplinary team, and to continue to work on those issues. Our organization is an AIAS Bologna is a non-for-profit NGO. It's driven basically by end users, people with disabilities and parents. But actually we decided over the last years to specialize increasingly in an area where we already had a long tradition, that is technology and disability, and enlarging our scope of our interest into digital healthcare. So to see not only what technology can do for people with disabilities in empowering them and increasing their quality of life, but also to look into how people with chronic conditions, or in general, the older people, can actually benefit from technology to better manage their conditions and at the same time being more integrated in the community. So the PROACT project gave us a big boost in setting up that activity. In the term "we care more," the "more" does not really refer to the pretension to feel better than others, but "more" stands for technology, the intelligent use of technology in making sure that people get the service that they deserve. So the organizations we would like to work with in the area of Bologna, and that partially we're already working with, are organizations that provide services but that are challenged by the digital revolution. They would like to do more. They would like to understand how technology can be an important driver for making their services more, let's say, reaching out to a larger community, and raising the quality of what they provide, if possible, also in a more efficient way. So those are basically public care providers, because in Italy we have a public healthcare system which guarantees services, but also private companies that deliver care. And we try to learn together with them and to advise them on how that step into the digital world could be best made, avoiding mistakes that maybe others have already made. So together with the networks, the European networks that we belong to, we are part of the Association for the Advancement of Assistive Technology and the European Association of Service Providers to Persons with Disabilities, who are also consortium members both in PROACT and in SEURO. We try to bring that discussion on a European level, looking especially into the factors that impact on the successful transfer of solutions that have demonstrated to work well in one context into another. And so that's also the reason why we are active in this project, again in trying to make the pro-transfer tool out of the model, which was already illustrated by John as an output of the PROACT project, and to make that into a workable tool for organizations to assess their readiness level to address these challenges and to successfully adopt in their organizations tools like PROACT. So again, it's great to be back here. Thank you, John, for having us involved again also in SEURO. And I just use 20 seconds to bring to your attention that we are also involved in the organization of the ICCHP AAATE conference, the joint conference which will be held in Lecco in Italy in July, and where we will have a special thematic session together with the SEURO partners and partners from another European consortium, the SHAPES project, to take this discussion further and also to make sure that it doesn't, it gets the attention that it deserves. But you all know with the aging population that we have in Europe, it definitely won't get off the agenda soon. So you're all invited there, and thank you again, Dr. Schmitt, and thank you again, Dr. Doyle, for your hospitality today.
Thank you very much, Evert-Jan, for providing us insight what the project actually means for your institution, how it feeds into the activities of your institution. The next speaker will be Professor Ann Jacobs, Principal Investigator of Studies on Media, Innovation and Technology, imec, Belgium.
Thank you for the invitation. Yeah, I'm representing today imec, and imec is a global research organization specifically interested in creation of new nanotechnology, microchips, and I'm a sociologist by training, so how did I end up there? It's because of their interest also from going from the very raw, basic sensors, new sensors making, towards these services implemented in daily life. And that's where we're trying to bridge with our research, with our team in Brussels. And we are also part of this more huger program, which is called One Planet, which is focusing also on behavioral change, on personalization, and there we have this huge opportunity to also connect with our Dutch research partners, for example, who are currently, for example, developing a new digestible sensor to monitor what's happening with nutrition. So can you imagine what we are creating today with mobile, still quite clumsy kind of devices that are there in the market, and we are trying to research and understand, very people-centered, like how will this be integrated in our daily lives. And they are developing, they are now doing animal studies, how it's going, and then imagine within 10 years, this kind of information resulting in new kind of solutions, revolutionize digital healthcare even more. So that's why we are from imec interested in taking part in this very nice project. And also I am very happy to be standing here again. I also was part of the PROACT project, and it learned us a lot. And I was also very happy to have all these like-minded people. I didn't need to struggle about personalized development, about people-centered design. No, it was taken for granted. Everybody was in from the very first moment. So we could go much faster than we can in other projects. I think that's also the base of success, and also the base why we managed, because the odds actually to have a second grant is really low. We have acceptance rates between 10 and 20%, depending on the call, and then we were there again. And we could also enrich our consortium with new partners, which is really great, because it's helping us to give us a fresh look. To look at it also from another cultural system, from another healthcare system, seeing like, is it still working? Is this transferability? Are all those tools really helping new organizations to come with us and help to deepen the solution? Because we had a proof of concept, and now we're evolving, maturing the system, making it better, making it more personalized, and we are collecting more evidence. different ways. We learned a lot about how to collect the data, what's working, what's not, and we had a lot of challenges to overcome, and I'm sure we learned a lot how to do it differently this time, and yeah, I'm really looking forward to doing this great experiment, comparing Sweden, Belgium, and Ireland, and see how can we prove that this is really giving a difference for quality of life and for care cost utilization. So thank you very much. Looking forward to see you again at the end of the project.
Thank you very much, Anne, for giving us a vision where the research, how the research can feed into imec, and thank you very much for this. The next speaker is Anna Nordström, Department of Public Health and Clinical Medicine, UMEÅ University in Sweden.
Thank you. So I'm from the northern Sweden. We still have snow up there. It's cold in the north. Region Västerbotten, where I'm also a doctor. We are in charge of the 4 northernmost regions in Sweden. Our own region is as big as Croatia. And we have 360,000 citizens, and the majority of that is elderly. We already today know that we can't manage the care for our elderly in a quality way. At the same time, we are in the middle of a health transformation. The digital transformation of our healthcare in the brink is that we are shrinking down the hospitals to manage critical care and then trying to transform the healthcare to be better at home. And that's where I think SEURO is spot on where we are at today. At the same time, in Sweden, in the northern parts, we are actually leading in 2 ways. One is in innovation. We have a lot of the infrastructure already in place. We have 5G net, for example. The elderly in our society, they are connected. Over 98% of our population is connected. So they are using tools already, but it hasn't really penetrated into healthcare. And that is something where I feel SEURO is, again, on spot. And how can we use this? Because technology will never be good if it's not user-friendly for the ones that are actually going to use it. So how do we get there? It's by trial and error, again and again and again. And sadly to say, it's not as easy in healthcare as it is in consumer markets. In 1957, don't know if all of you know, but one of the first smartphones, or mobile phones, I should say, not smartphones, was Ericsson. And they were more mobile as you could move it rather than have it in your pocket. And you could even have it in your car, and it cost as much as the car. Today, Ericsson is not the number 1 leading in mobile phones anymore, but it's one of the bases where we are all connected today. And I think that trial and error and listening to the users is the key to this. And I'm really happy that Region Västerbotten and UMEÅ University can be a part in this and trialing out the technology, and we're really happy for that. So thank you.
So thank you very much, Anna, for showing the potential impact of the project at your country and at your institution. So thank you again, all speakers. It's really fantastic to have you here. It's fantastic to get an insight into your roles, into your motivation, and into your ambition for the project. So thank you very much for this. So it will be really exciting to monitor the project and see the outcome and see the outcomes of the project. So now we come to the end of the event, but before I let you go, to have lunch, which will be provided in the foyer. I would like to thank again the Provost for attending, for marking the event, and I would like to thank all of you for attending. And obviously, I wish the project I wish John and the team and everybody all the best for the next few years, obviously for the project, for the outcome of the project, but also for many future collaborations to come out of this, because I think it's exciting. I can see significant synergies here between the entities, so I expect many more projects to come out of this collaboration. So thank you very much for everyone, best of luck. And I invite everyone to lunch, as I said, and refreshments, which will be served in the foyer. So thank you very much, everybody, for attending. Thank you very much.